Good morning. This is the PowerPoint presentation for theory number 7, part 2. And we will review our slows next time we meet in class. Okay. The first topic we will be talking about is something called hyperemesis gravidarum. This is past normal morning sickness, during pregnancy. It's more than just morning sickness. It occurs in about 50 to 80% of all pregnancies, typically beginning at the 4 to 10 weeks. Usually it's gone by the 20th week, but it can persist in some form or fashion throughout the whole pregnancy. This is terrible vomiting, prolonged vomiting, excessive vomiting, not just in the morning or brought on by certain smells or something along those lines. And actually, the woman can get so dehydrated that she has electrolyte imbalances, she can lose weight, she can go into problems with nutrition, and she can also have ketones in her urine, which means protein is breaking down, obviously. So our initial care is, of course, we have to make sure we get a good history of what's been going on, trying to find out what her dates are, etc. So we need to see and how long it's been going on, and all those things all those questions we need to ask. Of course, we need to get a first initial set of vital signs, get an initial weight, check the fetal heart rate, all of those things that we need to do. And of course, we'll probably go ahead and get a urine specimen and check it for anything unusual, especially ketones. We're going to be looking for that. More than likely, if she's dehydrated and not able to keep anything down, we're going to go ahead and start some IV fluids on her. If nothing else, just to correct a fluid imbalance, but possibly we may also have some electrolyte solution like lactated ringers, possibly. And we may add some additives to the IV fluid. We're going to try to get that nausea and vomiting under control, and the drug of choice for that is Zofran. And then, of course, if it would be necessary, we might go ahead and do some enteral nutrition, which means she would have to have a feeding tube put in. Remember, this is extreme issue here. Most of the time, with anti-nausea medication and fluid replacement, they do pretty well. And then, of course, we're going to take comfort measures as far as our nursing interventions, keeping her comfortable, keeping her mouth moist with swabs or maybe some ice chips, good oral care, lots of emotional support. This is very disturbing, obviously, when you're pregnant. You're going through a lot of changes anyway, and then not to be able to eat or have any food or drink, it's very problematic. So obviously, lots of emotional support. And then, of course, after we get the problem under control, the follow-up care, she may need to come back instead of 1 month, maybe a couple of weeks, and then we can reevaluate and see where we need to go from there. Okay, so next topic is hypertension during pregnancy. There's different kinds or different terminology, if you will. Gestational hypertension, preeclampsia, eclampsia, and of course, chronic hypertension, which means it was already there, it was pre-existing. So let's talk a little bit about some of these issues. So it's a common medical complication of pregnancy, is not unusual. They are the most major cause of perinatal morbidity and mortality worldwide due to the following: uteroplacental insufficiency. In other words, something is not getting to the placenta that needs to be there, and actually the placenta is the major problem. And then, of course, this can result in premature or preterm birth. Of a maternal deaths worldwide, 10 to 15% can be attributed to preeclampsia and eclampsia, which means hypertension really accelerated and exacerbated. And preeclampsia accounts for more than 50,000 maternal deaths each year. Now that would be probably someone who is not under medical care, prenatal care possibly, but it can happen at any time. So morbidity, comorbid things that can be a result or offspring, if you will, of this condition: renal failure, some types of coagulopathies, cardiac or liver problems, placental abruption, seizures, and stroke can happen as a result of preeclampsia or eclampsia. And you can see here that it is also a cause of mortality. So gestational hypertension is blood pressure that's elevated after 20 weeks of pregnancy. Remember we talked about in the previous class about the hydatiform mole, or the gestational trophoblastic disease, where they have signs of preeclampsia before the 20th week. So that would give us a clue that this might not just be gestational hypertension, in addition to other signs that we talked about. The blood pressure, again, is elevated after 20 weeks of pregnancy. However, there is no protein in the urine, all right? It's not unusual for a pregnant woman to have a trace of protein in her urine. That is not necessarily problematic. Obviously, we would want to keep a close eye on that. Also, we have to remember that if this is like this after 20 weeks, we need to be very, very vigilant about screening for it progressing to preeclampsia. Then if this hypertension persists 6 weeks after the birth of the baby, then chronic hypertension is probably going to be a thing for that lady. This is from your book, Risk Factors for Pregnancy-Induced Hypertension. We don't call it, or pregnancy-related, excuse me. We used to call it pregnancy-induced, but we've changed it to gestational hypertension or pregnancy-related hypertension. You can read this on your own. So along with, so we're going to move from gestational hypertension now on to signs and symptoms of preeclampsia. All right. So lots of times women will have high blood pressure, greater than 140/90, like we've talked about before. They'll also have more protein in their urine, and they'll start to pick up edema. They'll start to have generalized edema in the face, the lips, the hands, the feet, the ankles, and even sacral edema. Edema at the sacrum. When she sits for a long period of time, not only will she have edema in her feet and ankles, but if you checked her sacrum, you could probably have some pitting back there. Here is a picture of pitting edema. Now this is a way to sort of gauge the severity of pitting edema. Now we don't go around necessarily measuring the indentation that we make with our fingers. We actually use our index finger and our middle finger, not just one, to press into the area for about 3 seconds. And then when you let up, the longer it stays indented, the more severe the pitting is. Now, generalized edema, there's really no pitting. They just look really puffy. It may not be pitting, but it will be eventually if we don't intervene. Okay. I'm turning my page here. Okay, so this is from your book also about how to assess for edema. We generally rate it from non-pitting to +1 to +4. So you can look at that. I would advise you to be familiar with that. Okay, so preeclampsia is a progressive disorder with placental problems at its root. Hold on a minute, I gotta go get my magnifying glass. Okay. The progressive disorder with placenta as the root problem. It begins to resolve after the placenta has been expelled. We're talking about preeclampsia here. In a normal pregnancy, the spiral arteries in the uterus normally become larger and thicker to handle increased blood volume. In placental preeclampsia, this vascular remodeling does not occur or only partially develops in women with preeclampsia, and decreased placental perfusion and hypoxia result. Let me read that again. This is not on a slide. This is from my own notes, but I can share it with you if you need it. This vascular remodeling, remember it says that the spiral arteries in the uterus normally become larger and thicker to handle increased blood volume. We've talked about this blood volume a lot, okay? This vascular remodeling does not occur or only partially develops in women with preeclampsia, and there's decreased placental perfusion and hypoxia as a result. All right? Okay, more about preeclampsia. So if there's placental poor perfusion, we have placental ischemia. We have generalized vasospasm, which results in poor tissue perfusion. We have increased peripheral resistance and blood pressure. We already know we have increased blood pressure. We have decreased kidney perfusion, and we have decreased liver perfusion, and we also can have some neurologic complications, which we will find more about here when we start getting more and more into preeclampsia, eclampsia, and HELP syndrome, which can result, these neurologic complications can result in vision problems, blurring of vision, seizures. Not a good situation for your pregnant woman and her baby. Also knowing because of the abdominal area and the liver not getting perfused, we're going to have some epigastric pain, which you're going to hear more about. So sometimes the eclampsia may be mild. We may have some sort of mild elevation of the blood pressure. We may have some maybe 2+ protein, mild swelling. And so sometimes we can let ladies go home and rest, okay? Because, you know, we got placental problems. We got to rest. And so there's going to be activity restrictions like bed rest or limited activities of some sort. No running the sweeper, no picking up things heavy, no heavy housework, light things, resting frequently, laying on the left side so that vena cava is not compressed and they get more blood flow, okay? Monitoring fetal activity, we're going to have her maybe do some kick counts, baby movements. More than likely, she may come in for weekly non-stress tests. Also, at that time when she has the non-stress test, we will also check that blood pressure, measure the weight, look at the urinalysis, the UA again. We may restrict her salt intake. And this is more common, this preeclampsia type of thing is more common in your prima gravida who is less than 19 years old or greater than 40 years old. So it's more common in early young pregnant women on their first pregnancy. And also part of the activity restrictions is generally they do not advise sexual intercourse. So everything has to be kind of restricted, if you will. All right. So that's the mild preeclampsia. Now, preeclampsia can progress to eclampsia quickly if it's not managed appropriately. Okay. So preeclampsia, is the progression of the preeclampsia to generalized seizures. Okay, we've gone from bad to really bad. We've gone from just simple high blood pressure and maybe a little bit of protein, maybe a little bit of swelling, to full eclampsia. Now remember, there's mild preeclampsia, and it can progress to more severe, and then not very long after, especially if we do not intervene, we will have eclampsia. Okay. We use magnesium sulfate to prevent seizures in preeclampsia. Many of you, when you did your medication list, you wrote down that we use it for electrolyte replacement. That is not the case in this situation. So I may have commented on your med list. No, you didn't get it right. That for this patient, in this scenario, magnesium sulfate is given to depress and raise the seizure threshold so that they don't have a seizure. Because think about having a seizure and having an unborn baby inside you. It's extremely dangerous. Okay, I'm drinking coffee. Let's see. 50% of preeclamptic women develop the condition while pregnant. Okay, so half women do it. We can also have eclampsia that follows after the birth, and so that's pretty significant. All right. There's going to be lots of protein in the urine. We are going to start the magnesium sulfate. More than likely, we will give a loading dose, and we will kind of go over that again in class about how we do that. We give a loading dose, and then we follow it up with an infusion. We have to really watch this lady, because one of the bad side effects of magnesium sulfate is you can get hyporeflexia, which means your reflexes are diminished, and that can include anything from the deep tendon reflexes all the way up to your gag, your swallow, your cough reflexes, and which can precede respiratory depression. So one thing we always check, this is important to remember, we always check their reflexes and monitor that respiratory rate very carefully. It's possible while she's on this mag drip, and remember, this might be happening around 28 to 32 weeks, and we don't want to deliver that baby unless we absolutely have to. And so she may be on mag for a while before trying to get that baby to be a little more mature for delivery. And so she's going to be in the hospital, and she's going to be monitored closely. And we're going to check those reflexes. We're going to watch that respiratory depression. Obviously, we're going to check all those vital signs, the fetal heart rate, the fetal activity, all of the things that we've already talked about, but we're going to add to our focused assessment here and check those reflexes and the respiratory rate particularly. And we're going to watch the blood pressure. We might add in some antihypertensive medicines, and there are several of them listed on your medication sheet: methyladopa, hydralazine, labetalol. We will not use an ACE inhibitor. We will not use an ARB. We will use those particular beta blockers, more than likely, and they can be taken orally, although labetalol can be given IV push, hydralazine can be given IV push. Methyladopa is the preferred one, but they have had some success with the others. All right, and this would be very individualized based on the patient presentation. And we're going to control the external stimuli, because remember, we're trying to raise the seizure threshold. In other words, it's going to take a lot of stimuli and problems to induce a seizure. So if we control the environment, we keep it quiet, we may lower the lights from time to time. The TV should not be blaring 24/7. The cell phone in the game should be turned off. Remember, we're trying to prevent seizures. We do not want this patient to have seizures. And so we're going to take seizure precautions. We're going to pad the bed. We're going to have suction available. We might have an oxygen source available if it's needed. We're going to, some hospitals actually have rooms that have surveillance cameras in there in the event that a seizure would start. It would be seen more quickly, hopefully. So it just depends on your situation. Now, we talked about earlier the placenta being the problem. Well, the main treatment of this preeclampsia, the best treatment, is to get the baby out. But remember, it could be way too early for this baby. And so that's why we do the magnesium sulfate. God forbid you have a lady who's seizing, all right? We want to do preventive measures. Obviously, we said that already. Watch for signs of impending seizure. I don't know if you remember that, but sometimes the woman may have an aura, like something's not right, I feel funny. They may have more epigastric pain. They may have a metallic taste in their mouth, all kinds of things. And you should be educating your patient on reporting any unusual things. It may not be a seizure, but you wouldn't want to take a chance, obviously. So if your patient is having a seizure, you do not, under any circumstances, try to restrain her, hold her down. You will break her bones. Do not try to force anything between her teeth. If her jaws are clamped shut and you try to force them open, you could do injury. You could break all those beautiful porcelain denture or dental implants, and they will sue you. So don't do that. If she's going to have a seizure, she's going to have a seizure. Now, we can have medication on hand to, like Ativan or diazepam Valium to stop it, but they're going to have a seizure. All right, so don't restrain them. Don't try to force anything in their mouth. If at all possible, just protect them from injury. Turn them to their side if possible. And then, of course, monitor for signs supporting their family, because it's terrifying if they're there when they see it. And then also, we want to make sure that as we're running this magnesium sulfate, that we're probably checking her magnesium level and watching for signs of toxicity. And if she has signs of toxicity, you're going to get that hyporeflexia and depressed respirations. So don't wait till it gets to that point. More than likely, you'll check them maybe daily or every other day. Okay, sometimes because of this placental issue, women develop what's called HELP syndrome. Stands for hemolysis, elevated liver enzymes, and low platelets syndrome. All right. Hemolysis recurs as a result of fragmentation and distortion of the erythrocytes during passage through the damaged blood vessels we talked about earlier. Liver enzymes elevate because when hepatic blood flow is obstructed by fibrin deposits. The low platelets are caused by vascular damage resulting from vasospasm. This is all very hardcore physiology here. And they also get pain of upper right quadrant. This is a variant of severe preeclampsia. The clinical presentation, in addition to all these lab values that are out of whack, the patient will be complaining of this malaise. Oh, I just don't feel good. I'm just dragging. I just feel bad. They may even have some flu-like symptoms, aching, body aches, a little low-grade temperature, that kind of stuff. But then they're going to complain about the epigastric pain. They start talking about epigastric pain and seeing double things and blurred vision. You better intervene because we're fastly approaching a seizure. So we need to educate our patients about this to tell us these problems. The symptoms seem to be worse at night for reasons we really can't explain. And so education and close monitoring is very, very important. So our care management of this situation, we are going to check that blood pressure. These people are going to probably be in the hospital on bed rest with bathroom privileges, maybe out of bed for meals, that kind of stuff, but they're going to be restricted. We're looking at the edema. Although we don't always associate edema with preeclampsia, it could be just puffiness from being pregnant, extra volume, but we always want to assess it. Okay. Check those DTRs, deep tendon reflexes, and I'll show you a video of that when we meet for class next. Watch for hyperactive reflexes or clonus. We'll talk about that. Proteinuria is ideally determined by an evaluation of a 24-hour urine collection. Although they may not do that, they may still just send it down for a UA. But if it's indicated, they may go ahead and do a 24-hour urine collection. We are evaluating for signs and symptoms of severe preeclampsia going into eclampsia. Headache, it's going to be a very severe headache. It's probably going to be more frontal in the front of the head. Epigastric pain, particularly right upper quadrant. Visual disturbances such as photophobia and blurred vision. And so we're very, very vigilantly watching this patient, ready to intervene. Okay, let's see. The goals of all of our care are to ensure maternal safety and formulate a plan for delivery. Okay, seizure precautions we said. Controlled environment, mag sulfate, antihypertensive, we've already talked about that. We will be talking about what a normal magnesium level is in class. If the patient is on mag sulfate, we're to hold the drug if the respiratory rate is less than 12. There's absent DTRs, and the urine output is less than 30 milliliters an hour. Okay, let me say that again. We're going to stop the infusion if the respiratory rate is less than 12 per minute, they're absent deep tendon reflexes, and the urine output is less than 30 milliliters an hour. That could be a sign of magnesium toxicity. Another sign of that is extreme thirst. So that is our plan of care. And again, as we're going along, we're going to be talking about how we're going to take care of this baby as well, because we have to make sure that if we keep that baby in there long enough, then we can have a healthier baby. All right. So if the pregnancy is far enough along, maybe 32 weeks and above, possibly, and it's, we cannot seem to get this patient managed, we'll go ahead and give some surfactant or some dexamethasone to try to improve the lung function of the fetus. And we'll just have to go from there. NICU will be alerted, of course. And, that would be a last ditch effort, if you will. Okay. Chronic hypertension is hypertension that is already present before the woman got pregnant, or it's women with chronic hypertension are at increased risk for preeclampsia. That makes sense because they already may have some renal issues, they may have some vascular issues already going on, and so they should be monitored more closely for protein in their urine and edema. Antihypertension medication should be initiated if the diastolic blood pressure is higher than 100. I hope so. And of course, heredity and race play a significant role. We know that African American women have a higher incidence of high blood pressure, as well as women who have had a mother or another relative who had high blood pressure and or gestational hypertension. This type of hypertension affects about 4 to 5% of pregnant women. Ideally, the management of chronic hypertension in pregnancy begins before conception. Yes, I hope so. Of course, with high blood pressure, as we talked about earlier, there's more of an incidence of abruptio, placenta, some preeclampsia on top of your high blood pressure, and increased perinatal mortality, intrauterine growth restriction, and preterm birth. No ACE inhibitors at all, like we said. So labetalol, methyladelpa, hydralazine, those are the drugs of choice. Okay, so sometimes there's an incompatibility between mother and baby blood, all right? That's the RH incompatibility. The RH negative woman conceives a child with an RH positive papa, okay, and the child is RH positive, okay? So the maternal antibodies then develop after exposure to this RH positive blood, all right? Now, usually the first pregnancy is pretty much okay. If there's ever any doubt, we'll go ahead and give RhoGAM, all right? We'll go ahead and give the RhoGAM, especially after delivery for future pregnancies. And then you have the ABO incompatibility as well, and either one of these, now of course the RH incompatibility, if it's not found and it's not treated, the mother's antibodies will actually attack the baby and the baby will die. So that's why RhoGAM is so important. And then the ABO incompatibility, oftentimes hyperbilirubinemia is a problem in your newborn. So this is from your book, and you can look at this.